1. A 9-year-old male presents to the pediatric A&E department with a history of increasing drowsiness over the last 24 hours. Neurological assessment reveals that there is absence of upward gaze. A CT brain is requested which reveals hydrocephalus, with marked dilatation of the lateral and third ventricles. The fourth ventricle is unremarkable, and there is obliteration of the ambient cistern due to mass effect from a hyperdense mass noted posterior to the third ventricle. This mass has some central areas of calcified cation. There is no evidence of hemorrhage. An MRI is carried out following insertion of a shunt to decompress the ventricles. On sagittal sequences, a lesion is located between the splenium of the corpus callosum and the tectal plate, which exerts mass effect. This lesion is of intermediate signal intensity on both T1WI and T2WI, and displays avid contrast enhancement. Enhancing meningeal lesions are also noted in the spinal cord. Answers. Indicating 6. Indicating seeding. What is the most likely diagnosis? A. Pituitary teratoma. B. Meningioma. C. Pineoblastoma. D. Germinoma. E. Pineal cyst. Six. Central nervous and head and neck. 1. D. Germinoma. The lesion is described in the pineal region, so the differential of pineal tumors should be considered. These are differentiated between germ cell tumors and pineal cell tumors. Germinomas account for 40% of all pineal region masses and are much more frequent in males than females. They are also the most common germ cell tumor, with teratomas and choriocarcinoma having different imaging characteristics. The main differential in this case is between pineoblastoma and germinoma, as both occur in patients of this age group and both are hyperdense on CT. Imaging features described to help differentiate are the avid enhancement, which is more characteristic of germinomas but can occur in either. Central calcified cation is seen commonly in germinomas, but is uncommon in pineoblastomas, and when it occurs is often peripheral, giving the impression of an exploded pineal gland. Subarachnoid seeding is seen in both tumors, and if present CSF sampling can yield a tissue diagnosis. Pineocytomas occur in an older age group and infrequently cause subarachnoid seeding. Smyrniotopolos J, Rushing E, and Mina H, pineal region masses, differential diagnosis. Radiographics 1992, 12, 35, 77, 596 Grossman R and Usam D, Neuroradiology, The Requisites, 2nd ed., Mosby, 2003, pages 156-162. 2. D, Symmetrical involvement. Cyst. Cyst. 2. A patient presents with recent onset neurological symptoms suspicious of an acute presentation of multiple sclerosis, MS. Which of the following anatomical sites of plaque involvement is least consistent with this? A. Corpus callosum. B. Spine involvement in the absence of brain involvement. C. Cerebral cortex. D. Symmetrical involvement of cerebral white matter. E. Floor of the fourth ventricle. Question 7. Involvement of cerebral white matter. Symmetrical involvement of the cerebral hemispheres or cerebellar peduncles is unusual in MS, and is occasionally seen in acute disseminated encephalomyelitis, ADEM. ADEM can mimic an acute presentation of MS both clinically and in terms of imaging Phi endings. The monophasic nature of ADEM can be deduced both from the uniformity of lesional edema and contrast enhancement in the acute phase. Lesions in ADEM resolve on follow-up, and although enhancing and non-enhancing lesions can coexist for a period, new lesions should not appear. Involvement of cerebral white matter. Symmetrical involvement of the cerebral hemispheres or cerebellar peduncles is unusual in MS, and is occasionally seen in acute disseminated encephalomyelitis, ADEM. ADEM can mimic an acute presentation of MS both clinically and in terms of imaging Phi endings. The monophasic nature of ADEM can be deduced both from the uniformity of lesional edema and contrast enhancement in the acute phase. Lesions in ADEM resolve on follow-up, and although enhancing and non-enhancing lesions can coexist for a period, new lesions should not appear. MS plagues are classically seen in the periventricular and juxtacortical white matter. The other options in the question are all common plaque locations. Locations. Involvement of the corpus callosum is characteristic. Other common supratentorial sites include the white matter abutting the temporal horns and trigones of the lateral ventricles. Cortical lesions are less conspicuous on MRI than white matter lesions, but their detection is improved by the inclusion of a flare sequence. Juxtacortical white matter lesions are highly suggestive of MS, as lesions are not commonly seen in this region in normal aging. 12% of patients have lesions on MRI limited to the spine without brain involvement. Pretorius PM and Quaggabeer G. (238) Central nervous, head and neck questions. 3. A 45-year-old female patient is referred to you with a history of mild confusion and new onset seizures. This patient has a history of breast cancer and is currently undergoing chemotherapy following a wide local excision with axillary radiotherapy. The patient has a low-grade pyrexia and a low neutrophil count. An MRI reveals a solitary lesion in the right frontal lobe, which is low/intermediate signal on T1WI and high signal on T2WI. The lesion demonstrates ring enhancement. Diffusion-weighted imaging, DWI, reveals slightly increased signal on B1000 imaging, with increased signal on B0 imaging, and this area is bright on the apparent diffusion coefficient, ADC, map. What is the most likely diagnosis? A. Abscess. B. Metastasis. G. The role of MRI in the diagnosis of Ms. Clinical Radiology 2003, 58, 434 for 48. 3. B. Metastasis. The answer options give some of the classical radiological differentials for a ring-enhancing lesion in the brain: MAGIC DR, metastasis, abscess, glioblastoma multiforme, infarct, contusion, demyelinating conditions and post-radiotherapy change. The clinical history should steer the central nervous, head and neck answers 261. Reader toward the Phi RST2. DWI is reasonably useful at differentiating between these two, exceptions being in some fungal infections and toxoplasmosis, with necrotic metastasis having unrestricted diffusion and abscess having restricted diffusion. The appearances in this case are slightly confused by the DWI B1000 imaging showing increased signal. However, the presence of increased signal on the ADC map correctly identify this as being T2 shine through, showing the importance of checking both sequences. Chapman N. and Nakialny R. Aids to Radiological Differential Diagnosis, 4th ed. Saunders, 2003, p. 433. Grossman R. and Yusum D. Neuroradiology, The Requisites, 2nd ed. Mosby, 2003, p. Metastasis. C. Glioblastoma multiforme. D. Infarct. E. Radiotherapy change. 4. A 69-year-old lady was admitted 10 days ago following an acute intracerebral hematoma diagnosed on CT. What are the most likely radiological Phi endings on the follow-up MRI scan of brain? A. Hematoma hypointense to gray matter on T1WI, hyperintense on T2WI. B. Hematoma hyperintense to gray matter on both T1WI and T2WI. T2WI. C. Hematoma hyperintense to gray matter on T1WI, hypointense on T2WI. D. Hematoma hypointense to gray matter on both T1WI and T2WI. E. Hematoma isointense to gray matter on both T1WI and T2WI. P. 143. 4b. Hematoma hyperintense to gray matter on both T1WI and T2WI. The MRI appearances of intracranial hemorrhage are determined primarily by the state of the hemoglobin, HB, which evolves with age. This can be staged as hyperacute, Phi RST few hours, acute, 1-3 days, early subacute, 3-7 days, late subacute, for 7 days to 1 month, or chronic, 1 month to years. Table 6.1 illustrates the sequential signal intensity changes of the evolving intracerebral hematoma. Table 6.1 The sequential signal intensity changes of the evolving intracerebral hematoma. Hyperacute, acute, early subacute, late subacute, chronic state of HB, intracellular oxy HB, intracellular deoxy HB, intracellular met HB, extracellular met HB. Hemosiderin. Magnetic properties: diamagnetic, paramagnetic, 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 superparamagnetic. T1 signal intensity L/P/L/P NN NN L/P. T2 signal intensity NPPP NNPP. Data from Parazel PM, Mackett S, Van Meyert E, Van Goghem JW, Van den Howie L, and de Schepper AM. Intracranial hemorrhage, principles of CT and MRI interpretation. European Radiology 2001. T2WI. 5. A 40-year-old man is being investigated by the neurologists for new-onset epilepsy. An electroencephalogram, EEG, indicates an epileptogenic focus in the left temporal lobe. An MRI is carried out. The hippocampal structures are unremarkable. A 2 cm lesion is noted in the subcortical region of the left temporal lobe. This lesion demonstrates mild enhancement. Areas of low signal on T1WI and T2WI are felt to represent foci of calcified cation. There is also an area of high signal on T1WI and T2WI seen inferiorly within the lesion, which probably represents an area of hemorrhage. There is a rim of surrounding edema noted on T2WI and FLUID attenuated inversion recovery flare. What is the most likely diagnosis? A. Hemangioblastoma. B. Desmoplastic infantile ganglioglioma, DIG. C. Decembryoplastic neuroepithelial tumor, DNET. D. Pleomorphic xanthoastrocytoma, PXA. E. Oligodendroglioma. (2001, 11, 1770, 1783). 5. E. Oligodendroglioma. Prior to evaluating the imaging characteristics, the patient's demographics should be considered in this case, as in all cases of intracranial masses, as it will help limit the differential diagnosis significantly. The patient is an adult, thus making DIG and DNET unlikely. Secondly, consider the temporal lobe location. Hemangioblastomas are usually infratentorial in location, especially in the absence of a history of von Hippel-Lindau syndrome. All the other lesions are classical temporal lobe tumors. Finally, considering the imaging characteristics, both PXA and oligodendrogliomas may be entirely solid, but cysts are commonly seen in PXAs. Calcified cation is seen in 60–80% of oligodendrogliomas, but is rarely seen in PXAs. Similarly, hemorrhage, while not typical of oligodendrogliomas, is rare in PXAs. Grossman R. Central nervous, head and neck questions 239. 6. A 52-year-old man is investigated by MRI of brain for a possible transient ischemic attack, TIA. Focal lesions of CSF signal intensity are identified at adjacent to the anterior commissures. The referring neurologist suspects that these lesions are chronic lacunar infarcts. What MRI phi ending suggests that these are in fact prominent paravascular spaces? A. No restricted diffusion on DWI. B. Hypointense on T1WI. C. Hyperintense on T2WI. D. Suppress on flare. E. Normal surrounding brain parenchyma. 7. A patient with a known diagnosis. And USM D. Neuroradiology, The Requisites, 2nd ed. Mosby, 2003, pages 137–141. 6. E. Normal surrounding brain parenchyma. Paravascular spaces, Fiorco-Robin spaces, are Pial-lined interstitial FLUID structures that accompany penetrating arteries, but do not communicate directly with the subarachnoid space. They can occur anywhere, but typically cluster around the anterior commissure. They follow CSF signal intensity, suppress on flare, and do not exhibit restricted diffusion. They can occasionally. 262 Central nervous, head and neck answers. Be giant when located within the midbrain. Lacunar infarcts will also be hypointense on T1WI and hyperintense on T2WI. Restricted diffusion will be seen when acute/subacute. They are typically of increased signal on flare, although will suppress if there is central encephalomalacia. A halo of surrounding high signal on T2WI and flare is typical of lacunar infarction, although up to 25% of prominent paravascular spaces can also demonstrate a slight halo of increased signal. Lacunar infarcts are also more typically seen in the setting of more extensive white matter disease. Osborne A.G., Blaser S.I., Salzman K.L., Katzman G.L., Provenzale J., Castillo M.E.T.A.L. Diagnostic Imaging, Brain, A. Mirces, 2004. Diagnosis of a neurocutaneous syndrome is having a routine follow-up MRI scan. This patient is noted to have a history of right retinal calcify cations. On MRI, a retinal lesion is noted in the right eye, which is increased signal on T1WI. The scan shows a 2 cm lesion in the left lateral cerebellar hemisphere. This is predominantly low on T1WI and high on T2WI, but has a peripheral nodular area, which has a central signal void and demonstrates enhancement on T1WI. A further small enhancing lesion is noted in the cervical spinal cord, with an associated syrinx. The appearances are unchanged from previous imaging. Based on these phi endings, which neurocutaneous syndrome does this patient have? A. Neurofibromatosis. Osborne A.G., Blaser S.I., Salzman K.L., Katzman G.L., Provenzale J., Castillo M.E.T.A.L. Diagnostic Imaging, Brain, A. Mirces, 2004, I-7, 2225. 7. E. Von Hippel-Lindau syndrome. This syndrome is characterized by retinal lesions variously described as being retinal angiomas, retinal hemangiomas, or retinal hamartomas. These lesions, Lindau tumors, cause retinal calcify cation, although this is also seen in NF1 and tuberous sclerosis, TS, from other causes. Causes. The phi endings describe the classical appearance of a cerebellar hemangioblastoma. These lesions can also be entirely cystic or solid in a minority of cases. A signal void and lack of dural enhancement help differentiate this from other infratentorial masses in adults. 20% of hemangioblastomas are associated with von Hippel-Lindau syndrome, and 80% of von Hippel-Lindau syndrome patients have this tumor. The spinal phi ending also indicates a further hemangioblastoma in the cord. Unlike in the posterior fossa, these seldom have fluid ovoids, but are associated with the development of a syrinx. Lung R, Biswas S, Duncan M, and Rankin S, Imaging Features of von Hippel-Lindau Disease. Radiographics 2008, 28, 165-79. Grossman R and Yusum D, Neuroradiology, The Requisites, 2nd ed., Mosby, 2003, pages 456-457. Chapman S and Nakialny R, Aids to Radiological Differential Diagnosis, 4th ed., Saunders, 2003, pages 450-451. 8a, Cerebral Autosomal Dominant Arteriopathy with subcortical infarcts and leukoencephalopathy, Cadasal. This is a hereditary small vessel disease, which causes stroke in young adults. The genetic E. Von Hippel-Lindau syndrome. 8. A 32-year-old man presents with recent onset of migraine and TIAs. He also reports some cognitive decline. Cerebral angiogram is normal. An MRI of brain reveals discrete hyperintensities in the anterior temporal poles and external capsules. What is the most likely diagnosis? A. Cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy, Cadasal. B. Mitochondrial myopathy, encephalopathy, lactic acidosis, and stroke, MELAS. C. Myoclonic epilepsy with ragged red fibres, MERF. D. Sporadic subcortical arteriosclerotic encephalopathy, SSAE. E. Protein S deficiency. Genetic mutation is found on chromosome 19. Presentation can include migraine, cognitive decline, psychiatric disturbance, TIAs, and stroke, the latter usually with substantial/complete recovery after individual strokes, particularly early in the disease process. Imaging reveals subcortical lacunar infarcts and leukoencephalopathy in young adults. The frontal lobe has the highest lesion load, followed by the temporal lobe and insula. Anterior temporal pole and external capsule lesions have higher sensitivity and specify CT for caudacil. The cerebral cortex is usually spared. MRI is the investigation of choice. CT will reveal only areas of hypodensity and angiography is normal. SSAE is associated with hypertension and results in multiple lacunar infarcts in the lenticular nuclei, pons, internal capsule, and caudate nuclei. MELAS and MERF are mitochondrial disorders. MELAS results in bilateral multiple cortical and subcortical hyperintense lesions on FLAIR images. MERF has a propensity for the basal ganglia and caudate nuclei, and watershed ischemia/infarcts are common. Hypercoagulable states such as protein S defy CNC result in cortical and lacunar infarcts of various sizes, but the cerebral angiogram is abnormal. Osborne AG, Blaser SI, Salzman KL, Katzman GL, Provenzale J, Hedlund GL ETAL Diagnostic Imaging, Brain, A. Mirces, 2004, I4, 60-65. '65. Central 240 central nervous, head and neck questions. 9. A 36-year-old patient with known AIDS is admitted to your hospital with a right-sided hemiparesis. His wife gives a history of cognitive decline, headache, and lethargy for the past few weeks, but with an acute deterioration in the last 36 hours. His CD4 counts are between 200 and 500, category B. An MRI is carried out which shows multiple ring-enhancing lesions in the brain. These lesions are high signal on T2WI/flare, but demonstrate a low-intensity peripheral ring. Lesions are noted in the basal ganglia bilaterally. The cortical region and subcortical U5 are spared. A thallium SPECT is also carried out that shows abnormal uptake in the brain, which correlates with the areas identified on MRI. What is your primary diagnosis? A. Nocardia abscesses. B. Toxoplasmosis. C. Progressive multifocal leukoencephalopathy. D. Primary CNS lymphoma. E. Cerebral cryptococcus infection. Central nervous, head and neck answers 263. 9. B. Toxoplasmosis. This is the most common intracranial opportunistic infection in AIDS patients, and the most common cause of intracranial mass lesions in this population, with lymphoma second and cryptococcus third. Differentiating toxoplasmosis from lymphoma has been the subject of much debate in the literature, and ultimately there is no definitive means of differentiating them on imaging alone. As described, toxoplasmosis causes multiple ring-enhancing lesions and often affects the basal ganglia. Lymphoma tends to involve the subependymal regions and can cause leptomeningeal enhancement. Lymphoma can cause encasement of the ventricle, which is not seen with toxoplasmosis. Toxoplasmosis tends to be higher intensity on T2WI/flare than lymphoma. PET and thallium SPECT have also been reported to show abnormal uptake in lymphoma, but not toxoplasmosis, although exceptions exist. Response to antitoxoplasma treatment is often used as a clinical differentiator. Cryptococcus classically causes dilatation of Fierco-Robin spaces. PML is a demyelinating condition secondary to JC virus of oligodendrocytes, and is differentiated from other HIV-related demyelinating conditions by affecting the subcortical U5. OFFIAC and Turnbull I. The imaging appearances of intracranial C. Infection. 10. CNS infections in adult HIV and AIDS patients. Clinical Radiology 2000. 10. A 50-year-old male patient is referred from A&E for a CT brain. He has a history of headache for 2 months and increasing clumsiness. The CT shows a lesion abutting the sphenoid in the anterior cranial fossa. It measures for centimeters in size and demonstrates heterogeneous enhancement. There is no evidence of calcified cation. The lesion is displacing and effacing the third ventricle, causing mild hydrocephalus in the lateral ventricles. An MRI is performed. The lesion is isointense on T1WI and T2WI and demonstrates an enhancing dural tail and broad dural base. Again, the enhancement pattern is heterogeneous. A number of fluid alvoids are noted in the lesion. There is little peritumoral edema noted. An Mr. angiogram is performed, which indicates dual supply to the lesion from the internal and external carotid artery. What lesion typically demonstrates these imaging phi endings? A. HU1 meningioma. B. HU3 meningioma. C. Hemangiopericytoma. D. Melanocytoma. Berger J. Mass lesions of the brain in meningiomas demonstrate uniform enhancement. Enhancement, although hemorrhage into meningiomas is recognized. HU3 meningiomas, malignant meningiomas, are indicated on imaging when there is invasion of the adjacent parenchyma. Parenchyma, which is not described. Otherwise, the diagnosis of malignant meningioma is made by an aggressive pattern of growth on serial imaging and biopsy. The dual arterial supply is also atypical. While meningiomas can have dual supply, they more typically derive their arterial supply from the external carotid via the meningeal artery. Melanocytomas are suggested on imaging by increased signal on T1WI and are more commonly infratentorial. Without this, the diagnosis is again reached most commonly following biopsy. All the features described are typical of hemangiopericytoma. Subtain N, but S and Connor S. Imaging features of central nervous system hemangiopericytoma. D. Melanocytoma. E. Schwannoma. 11. A patient is referred to your neurointerventional team for embolization of a meningioma prior to surgical resection. The lesion is based on the tentorium. What is the likely feeding vessel? Parent vessel is named in brackets. A. Anterior meningeal artery, vertebral. B. Middle meningeal artery, external carotid artery, ECA. C. Posterior meningeal artery, variable. D. Bernasconi-Casanare artery, internal carotid artery, ICA. E. Dorsal meningeal artery, ICA. Central nervous, head and neck questions 241. 12. A 7-year-old girl is brought into A&E with a history of hemangioperocytomas. European Radiology 2007, 17, 1685, 1693. Grossman R. Newsom D. Neuroradiology, The Requisites, 2nd ed., Mosby, 2003, 99105. 11. D. Bernasconi-Casanare artery, ICA. The majority of meningiomas occur in the parafalcine region, along the convexity, or around the sphenoid. These all derive their supply from the ECA, although parafalcine meningiomas can also receive supply from a branch of the ophthalmic artery. Tentorial or cerebellopontine angle, CPA, tumors are classically fed by the Bernasconi-Casanare artery, a branch of the meningohypophyseal trunk of the ICA. Lesions around the foramen magnum, clivus, and posterior fossa are fed by branches of the vertebral artery, anterior, and posterior meningeal, and meningohypophyseal trunk of the ICA. Grossman R. Newsom D. Neuroradiology, The Requisites, 2nd ed., Mosby, 2003, p. 104. 264 Central nervous, head and neck answers. 12. D. MRI due to deterioration in clinical course. In the absence of clinical features of raised intracranial pressure, a CT is not necessarily indicated prior to lumbar puncture to exclude raised intracranial pressure. CT is also insensitive at diagnosing meningitis, being normal in most uncomplicated cases. MRI is also negative in 50% of cases of uncomplicated meningitis. The value of imaging is in the detection of complications of meningitis, including hydrocephalus, abscess, cerebritis, venous thrombosis, and infarction. Hughes D., Rog van A., Moordecker S., Griffey THSP. Headache of 4 hours duration, associated with neck stiffness. The parents noted a petechial rash and are concerned about the possibility of meningitis. There is no photophobia and no other neurological signs are present. A&E have requested a CT scan to rule out raised intracranial pressure and to diagnose meningitis, whilst also commencing antibiotic therapy for presumed meningitis. The CT scan is normal. As it is a normal working day, A&E have also requested an MRI scan to diagnose meningitis. This was not carried out as the child was agitated. The following day the child develops a pyrexia and a right unilateral aspect to the headache with decreased GCS. An MRI is carried out and demonstrates features of developing right temporal lobe empyema. Which of the following is an appropriate indication for imaging in the investigation of meningitis? A. CT to rule out raised intracranial pressure. B. CT to diagnose meningitis. C. MRI to diagnose meningitis. D. MRI due to deterioration in clinical course. E. All of these. P. and Connolly D. Role of imaging in the diagnosis of acute bacterial meningitis. Meningitis and its complications. Postgraduate Medical Journal 2010, 86, 1018 for 78 for 80. $485. D. MRI due to deterioration in clinical course. E. All of these. 13. A 13-year-old boy is brought to your pediatric hospital. Hospital with a recent history of headache and high fever. The child is becoming progressively drowsy and demonstrates rigidity and tremor on neurological examination. An MRI is requested. Relevant past medical history on the request form is of recent travel to Asia, history of measles as a 6-year-old and recent viral infection. The MRI scan shows increased signal on T2WI and flare sequences in the hippocampal regions of the temporal lobes. There is also increased flare signal in the thalami and cutamina bilaterally. Small foci of increased T1WI signal within these regions are felt to represent hemorrhage. What diagnosis would you place at the top of your differential list? List. A. Herpes simplex type 1 encephalitis. B. Herpes simplex type 2 encephalitis. C. Japanese encephalitis. D. Varicella zoster encephalitis. E. Subacute sclerosing panencephalitis. S. Of acute bacterial meningitis and its complications. Postgraduate Medical Journal 2010, 86, 1018 for 78 for 85. 13. C. Japanese encephalitis. Japanese encephalitis and herpes simplex virus, HSV, encephalitis both present with similar acute and rapidly progressive neurological symptoms. The key differentiator is involvement of the basal ganglia, which is typical in Japanese encephalitis but rare in HSV. Both commonly involve the hippocampi, this being the classical appearance of HSV encephalitis. HSV type 1 is the subtype that affects adult and older children. HSV type 2 causes neonatal and in utero infection. Herpes varicella zoster virus, VZV, infection can be seen in immunocompromised children, but in the immunocompetent population is more typically seen in elderly patients, often, but not exclusively, in the presence of cutaneous shingles. It causes a vasculitis, which can be seen angiographically, and causes bilateral increased T2WI/flare foci and gyriform enhancement in the distribution of the vasculitis. SSPE presents with a more protracted history of neurological decline. Andrula C. Cranial viral infections in the adult. European Radiology 2004, 14, E132, E144. Grossman R. USMD, Neuroradiology, the requisites, 2nd ed., Mosby, 2003, 288304. 242 central nervous, head and neck questions. 14. An 8-year-old female patient presents to your pediatric neurology service with a history of increasing ataxia, repeated headaches, and vomiting, increasing in severity over the last 5 months. Clinical examination reveals marked cerebellar signs of past pointing and dysdiadochokinesis. An MRI is requested, which shows a solid mass in the posterior fossa measuring 2 cm in size. This mass arises in the left cerebellar hemisphere and displaces the fourth ventricle. It is of low intensity on T1WI and high signal on T2WI. There is only a small rim of surrounding edema. The lesion demonstrates relatively homogeneous moderate enhancement. There is no evidence of subarachnoid seeding. What is the most likely diagnosis? A. Pilocytic astrocytoma. B. Ependymoma. C. Medulloblastoma. D. Metastasis. E. Lermite-de-Clos syndrome. A. Pilocytic astrocytoma. This question deals with the classical neurological differential diagnosis of a posterior fossa mass in a child. While there are many causes, pilocytic astrocytoma and medulloblastoma account for over 60% of all childhood posterior fossa masses. Pilocytic astrocytomas have a classical appearance of being cystic lesions with an avidly enhancing neural nodule. However, 30% of pilocytic astrocytomas are solid tumors. In differentiating them from medulloblastomas, pilocytic astrocytomas often arise more peripherally and displace the fourth ventricle, whereas medulloblastomas usually arise centrally from the vermis. Subarachnoid seeding is seen in up to 50% of cases of medulloblastoma. Ependymomas are also included in the differential. As these arise from the ependyma lining the ventricle, they tend to be centered on the fourth ventricle in children. Metastases are the most common cause of a posterior fossa mass in adults, but are less common in children. Brandt W. and Helm C. Fundamental. A 30-year-old male patient is referred from Ent for an MRI with a history of tinnitus and slight hearing loss on the left side. A lesion is noted in the left cerebellopontine angle. This extends along the nerve and expands the internal auditory canal. A separate nerve is noted to enter the anterior superior portion of the internal auditory canal. The lesion is isointense to the pons on all pulse sequences. The lesion makes an acute angle with the petrous bone. There is no evidence of a dural tail following enhancement. What is the most likely cause? A. Meningioma. B. Facial nerve schwannoma. C. Vestibular nerve schwannoma. D. Epidermoid. E. Arachnoid cyst. Brandt W. and Helm C. Fundamentals of Diagnostic Radiology, Lippincott Williams and Wilkins, 2006, pages 135-142. 15. C. Vestibular nerve schwannoma. Even in the absence of the imaging phi endings, this would be a reasonable bet as it accounts for 75% of CPA tumors. However, assessment of the imaging characteristics increases the likelihood of this diagnosis. The second most common cause of CPA tumor is meningioma, 10%. Differentiating features are lack of a dural tail, acute angle with the petrous bone, seen in schwannomas, less commonly with meningiomas, which make an obtuse angle, and most importantly, expansion of the internal auditory canal, IAC. Facial nerve schwannomas can appear in the same site and appear identical, but they only constitute 4% of lesions in this site, and as such would not be the most likely cause. The facial nerve lies in the anterosuperior portion of the IAC, although it cannot usually be separated from the mass in the IAC on imaging. Grossman R. and Newsom D. Neuroradiology, The Requisites, 2nd ed. Mosby, 2003, pages 105-108. 16. An MRI is carried out for your neurology service on a 30-year-old male patient. The most pertinent abnormality is a fixed smooth meningeal enhancement following the dural arachnoid around the convexity, falx, and tentorium without extension into the basal ganglia or ventricles. The referring clinician arrives to discuss the phi endings, but has mislaid the request form and clinical information. While he is looking for it, what do you think the most likely clinical presentation is? A. Neck stiffness, photophobia, raised WCC, petechial rash. B. Neck stiffness, drowsiness, with history of breast cancer. C. Acute limb weakness on right side 3 days previously, not resolving. D. Recent back surgery complicated by ongoing CSF leak. E. Possible fungal meningitis in immunocompromised patient. Central nervous, head and neck question. Central nervous, head and neck answers 265. 16. D. Recent back surgery complicated by ongoing CSF leak. The key feature is the pattern of meningeal enhancement. It is important to recognize that the imaging phi endings describe patchymeningeal, not leptomeningeal, enhancement, and as such the causes of leptomeningeal enhancement, bacterial or fungal meningitis, can be discounted. Similarly, a recent stroke can cause gyriform enhancement, not patchymeningeal enhancement. Breast cancer is the most common malignancy to cause patchymeningeal enhancement, but this would usually be more nodular than smooth. CSF leak or any cause of intracranial hypertension will be associated with smooth patchymeningeal thickening, primarily over the convexities and falx. This enhances, not because of any infl amatory process, but because this part of the meninges has no blood-brain barrier, unlike the leptomeninges. Smyrniotopolos J. Murphy F. Central nervous, head and neck questions 243. 17. A patient is having an MRI scan carried out to investigate a possible right frontal astrocytoma, incidentally detected on CT following a head injury. The MRI features are typical of an astrocytoma, with no evidence of necrosis or callosal involvement to indicate glioblastoma multiforme, GBM. MRS has been carried out to help assess the grade of this tumor. What MRS features would indicate a high-grade lesion? A. Elevated choline, reduced N-acetylaspartate, Na, choline/creatine, CHO/CR, ratio of 1. B. Elevated choline, reduced Na, CHO/CR, ratio of 2. C. Normal choline, elevated Na. D. Reduced choline, reduced Na, CHO/CR, ratio of 1.2. E. All normal, these are unaffected by tumor grade. Smyrniotopolos J. Murphy F. Rushing E. Rees J. and Schroeder J. Patterns of contrast enhancement in the brain and meninges. Radiographics 2007, 27, 525, 551. 17. B. Elevated choline, reduced Na, CHO/CR, ratio of 2. Na is thought to be a marker of neuronal integrity, choline indicates cell turnover, and creatine indicates cell metabolism. Lactate is not detectable in normal brain spectra, but is elevated in inflammation, infarction, and some neoplasms. Most brain conditions, whether neoplastic, vascular, or demyelinating, are associated with a reduction in Na. A notable exception is Canavan's disease, which causes a rise in Na. Choline is elevated in many disorders, but is markedly increased in high-grade neoplasms. It has been reported that the ratio of choline to creatine can be used to help grade tumors, with a ratio over 1.5 indicating high grade in the majority of cases. A reduced choline and Na in an area of tumor can indicate necrosis. Soares D. and Law M. Magnetic resonance spectroscopy of the brain, review of metabolites and clinical applications. Clinical radio 18. Which one of the following orbital pathologies typically arises from the intraconal compartment? Fade N, Davila J, Medrano J, and Olmos S. Malignancy assessment of brain tumors with magnetic resonance spectroscopy and dynamic susceptibility contrast MRI. European Journal of Radiology 2008, 67, 3 for 27 for 33. 18. A. Cavernous hemangioma. The orbital compartments are split up into extraconal, conal, intraconal, and globe. The extraconal compartment consists of fat, lacrimal gland, and bony orbit. Pathology in this region includes infection, neurofibroma, adenocarcinoma, mucoepidermoid, and adenoid cystic carcinoma, neoplasia of bone, and lymphoma. Conal pathology, muscle, includes rhabdomyosarcoma, thyroid eye disease, and idiopathic orbital inflammation, pseudotumor. The intraconal compartment consists of fat, lymph nodes, vessels, nerves, and the optic nerve sheath complex. Pathology in this region includes venous lymphatic malformation, hemangioma, arteriovenous malformation, optic nerve meningioma/glioma, and lymphoma. Pathology in the globe includes retinoblastoma, metastasis, and melanoma. Aviv RI and Miscule K. Orbital imaging PART2. Intraorbital pathology. Clinical radiology. A. Cavernous hemangioma. B. Adenocystic carcinoma. C. Rhabdomyosarcoma. E. Orbital pseudotumor. 19. A 35-year-old man presents with tinnitus and hearing loss in the right ear. Investigations include an MRI of the internal auditory meaty. This demonstrates an expansile lesion in the right petrous apex without bone destruction. The lesion is of increased signal on T1WI, increased signal on T2WI, and non-enhancing. What is the most likely diagnosis? A. Cholesteatoma. B. Petrous apex cephalocele. C. Mucocele. D. Petrous apicitis. E. Cholesterol granuloma. Aviv RI and Miscule K. Orbital imaging PART2. Intraorbital pathology. Clinical radiology 2005, 60, 288307. 19. E. Cholesterol granuloma. The phi endings described are typical of cholesterol granuloma. A critical distinction is between this and a petrous carotid artery aneurysm, which may show similar features of increased T1WI signal. However, the presence of fluid void, lesion centered on the carotid canal, and additional complex areas of signal due to blood products of varying ages might be expected in an aneurysm. A petrous apex cephalocele is an area of fluid UID signal, hypointense T1WI, hyperintense T2WI, adjacent to the petrous apex that is in communication with Meckel's cave. 266 central nervous, head and neck answers. A mucocele of the petrous apex may cause benign bony expansion, and is typically of decreased signal on T1WI and increased signal on T2WI, and is non-enhancing. A cholesteatoma may have similar T1WI and T2WI signal characteristics, but these entities may be differentiated by DWI. On DWI, cholesteatoma is typically of increased signal, whereas a mucocele is of decreased signal. Petrous apicitis is an aggressive process that typically enhances with gadolinium, and is secondary to infection. There may be an accompanying history of infection, middle ear disease, diabetes, or immunocompromise. Connor SEJ, Lung R, and Nadas S. Imaging of the petrous apex, a pictorial. A 54-year-old lady with a history of exophthalmos undergoes a CT scan of orbits for assessment. There is spindle-shaped enlargement of extraorbital musculature that does not involve the tendinous insertions. Which pair of muscles is most likely to be involved? A. Superior and inferior. B. Superior. Connor SEJ, Lung R, and Nadas S. Imaging of the petrous apex, a pictorial review. British Journal of Radiology 2008, 81, for 27 for 35. 20. D. Inferior and medial. The question refers to Graves' ophthalmopathy, where enlargement of the extraocular muscles is observed, with sparing of the tendinous insertions. This is in distinction to idiopathic orbital inflammatory syndrome, where the muscle swelling typically involves the tendinous insertions. In Graves' ophthalmopathy, the extraorbital muscles are involved with decreasing frequency as follows: inferior, medial, superior, and lateral recti.